Hello, thank you, Gordon, for this presentation. I learned a lot, and in a way, I am just going to follow what you said. First, my disclosure. Then I am going to talk to you about personalized medicine. I'm sure you have all heard about that, and I'm sure you have been surprised that personalized medicine, in fact, at the beginning and still now, comes from cancer and in particular genomics. So, and if you look at the definition that was raised about 15 years ago about personalized medicine, it is treatment with the right drug at the right dose in the right patient. And in line with the presentation of Gordon, you have here much more what than how to prescribe. Okay, this is for cancer, and you know now for breast cancer you have KRAS plus, minus, and you adjust chemotherapy according to the genes that are present in the tumor. Okay. It can look very far from child and adolescent psychiatry. We do not genotype patients before prescribing medication, obviously, at the moment. So we could ask, is it really relevant for us? Well, today, obviously not, but in the future, why not? I'm sure that sometime you have comorbid patient with ADHD, oppositional defiant disorder, and conduct disorder. And when these patients are severe, this is not very clear to determine which medication to give first. For instance, risperidone or methylphenidate. And these two drugs have very different mechanism of action, very different side effects. And so what do? We try. And so this is not really scientific, and our patient can have side effects because we made the wrong decision. And perhaps if we had genes, brain imaging, things like that, that could help us in the determination of medication, it would be a progress. So why not a personalized medicine in the way we prescribe medication? But as psychiatrists, we could be a little bit confused by the fact that in the so-called personalized medicine, the person is considered through his or her genomes. Now, you know, you have proteomes, transcriptomes, etc., but more or less this is still the same thing. Why it is a little bit shocking? Because this is a translation of a biologization of patients. And it is a long story in medicine. You know, when you come back 3,000 or 4,000 years ago, in fact, there were already personalized medicine. With shaman, for instance, they did personalized medicine because the treatment they proposed to their patient took into consideration the cosmos, the spirituality, the family, etc., etc., and the herbs they gave were chosen according to the very particular patient. So at the very beginning, there were personalized medicine, and it didn't work so much. It didn't work so much, and it is because biology came progressively with dissection, anatomy, physiology, and up to the 19th century with physiology and experimental medicine. It is at this moment that medicine became very efficient. And so, okay, perhaps the patient, because medicine has to be efficient, because biology made medicine efficient, perhaps we have to consider that a person is a body with organs and genomes, perhaps. Okay. Even if it is at the cost of an epiphenomenalism of mind, and you have noticed that today, it is difficult to speak about the mind. You can speak about cognition, which is in a way how the brain processes data, but this is not the same thing as mind. And even between us, psychiatrists, it is difficult to be scientists and to speak about the mind. Okay, So what? So what? Perhaps this is some kind of romanticism. Perhaps we are sad about it, but that's life. To be efficient, perhaps we need not to be romantic. And you know that biology can help child and adolescent psychiatry, for instance, for unstigmatization of mental disorder. I'm sure you have experienced that. Nowadays, autism is considered mainly as a biological disorder, and in a way it helps to unstigmatize this terrible disease. Okay, until I read recently this very interesting paper published in December in PNAS, which is a very famous journal. You can download the paper, it is free on the PNAS website. This is 3 very clever experiments. It is about when you give biological explanation to the family of your patient or to your patient, has it an implication on your level of empathy with your patient? And the experiment is based on clinicians, about 100 of clinicians, and you give to the clinician some vignettes of patients. And there was an experiment on schizophrenia, one on emotional disorder, etc. And with this vignette, you give either biological explanation to the disorder or psychological explanation. And after you ask to the physician, well, how do you feel according to the patient? And there you propose to the physician 18 adjectives, some about empathy, some about distress, because perhaps it is good to evaluate distress as a confounding factor, because perhaps empathy is related to the physician level of distress, and 6 adjectives which are here only as fillers. And the result is that very consistently, when you propose biological explanation to the vignette, the physician feels a lower level of empathy than when there is a psychological explanation. While the level of distress is comparable, and another result is that psychiatrist has a lower level of empathy than psychologists and the non-medical profession. So, considering our patients through the genomes or through their brain can be efficient on a very pragmatic point of view, but it raises an issue about empathy. So you could tell me, after all, do we need empathy? In fact, there are data which show that empathy is important. First, empathy is related to good outcomes, and you know that empathy is related to therapeutic alliance, and therapeutic alliance is a major prognostic factor for the outcome of our patient. I remember here a very famous paper, a randomized controlled trial with antidepressive drugs, placebo. It was in adult psychiatry, nevertheless. Antidepressive drugs against placebo and psychotherapy against no psychotherapy. So very classical, but there was a measurement of therapeutic alliance. And the level of therapeutic alliance predict more the outcome than the fact you give an antidepressive drug or a placebo, or than the fact that you give a psychological treatment or nothing. So therapeutic alliance is a very important matter, while it is never studied in classical design, because when you compare a treatment to a placebo, therapeutic alliance is in both arms. When you prescribe a placebo, there is therapeutic alliance, and since you look at only the difference between the two arms, therapeutic alliance disappears from the results of the study. So, at this stage, what can you say? First, that you must be careful about this fashion of epiphenomenalism. We are psychiatrists. We are working by definition with subjects who have a mind. And this is important, and even there are data which shows that. And even if dualism is something a little bit old-fashioned, there were a paper in the Journal of the American Psychiatric Association, an editorial about dualism as something belonging to the past. Well, in fact, we are dealing with thinking subjects. Even if thought comes from the brain, you have to consider that patients experience mind and thinking, and even on a very experientialist point of view, you have to consider that dualism is relevant. Mind is important. So, what should be personalized medicine to conclude? First, this is the very basis, and I think that everybody agrees today. We need statistics because our practice is so complex that we have to do. Nobody, even the most sophisticated biological neuroscientist, cannot predict exactly what happens when you give a treatment to a patient. This is impossible. There are many, many things that we don't know. And in such situation where there is noise, you can only deal with statistics. And you know that you have to do randomized control trial to try to know, for instance, if antidepressive drugs are useful for adolescents or not, which is a very tricky question, but the only answer that you can have, well, the main answer that you can have comes from statistics. Of course, the problem of statistics is that even if they are efficient, they deal with an average subject that you will never meet. In front of you, you have not an average subject, you have one patient with his or her family. And in fact, all patients are very different, either on a biological point of view, and of course, you have to know that the liver, the kidney, the brain of your patient can be different from one depressive patient to another depressive patient, and that your medication, your treatment, your psychological treatment will have possibly a different outcome. And perhaps in the future, if we have tools to deal with this singularity, it will help us. Okay, fine, excellent. But on the other way, you have also in front of you a thinking subject. And this thinking subject is singular by essence. As people with a mind, we are all different. And we have to remember that the basis of medical practice is to deal with singularity. Why? Because what is the definition of a patient? When you ask that to students, most often nowadays they answer, well, a patient is somebody who has a disease, which is not the case. A patient has a complaint. This is the definition of a patient according to Georges Canguilhem, a physician, philosopher of the middle of the 20th century. A patient has a complaint. And in psychiatry, a patient has a complaint according to his way of thinking, according to his mind. And so because it is the constitution of the patient which is related to the complaint and to a subjective complaint, you have to deal with that, you have to deal with this subjectivity, and you have to deal with this singularity. Okay, this is very theoretical. And I have asked myself about a practical tool that could help us to deal really with singularity and to do a personalized medicine adapted to child and adolescent psychiatry. And I have found that in a recent publication done by Ethician about the notion of humility in medicine. Humility is not humiliation. Humility is not modesty. Humility is just the fact that as a physician, you feel superior. That's life. You have a dress, and you have a name, and this dress make you superior. And humility, it is just the fact that when you are in front of the patient and the family, you lower yourself up to acknowledge that you are similar to the person you have in front of you. And humility will help you to do personalized medicine because you will realize that you are a person and your patient is a person also. I thank you for your attention.